All right, hey guys. All right, so um, I promise I did not plan it this way that I'd be doing all 3 hours of lectures today. Um, Dr. Zin has rescheduled, so he'll be doing, instead of board review on Friday, we'll do board review today, and then we'll do approach to coronary angiography and complications, specifically in regards to us managing patients after they come from the cath lab on Friday. So please be on time for that one. We'll have a Jedi lecture today, then we'll take a break so that way you guys can get 30 minutes of quiz time to do your questions, and then we'll have review. We'll have a quick clinical case. Since you guys are on fellow A and B, you guys will be the people solving the case. Of what and fellow, you guys will be solving the case. It's not about getting the right answer. It's more like what your approach to diagnostic reasoning is. It'll be a team of ICU docs trying to solve the case. Both of you and Pratik as well. It's not about getting the right answer. It's really just about what your guys' thought process is, so everyone else can learn from you. If anyone else has thoughts, you guys can just chime in on the chat privately, and I'll throw in whatever you guys are chiming in. So for the Jedi lecture today, we'll go over proning like a pro. The reason I didn't actually make that the title was because I just thought of it, but also because when you actually look at the approach to proning, everyone does it differently. If you go to different institutions, and I'm sure everyone has seen different approaches to proning over the last couple of years, it's very hard to say who the pros are, but it really comes down to just lots of experience. And when it comes to us for fellowship, it's very important, obviously, to at some point go over key landmark trials, and obviously there's a key landmark trial in this one. So who here has proned before or led a proning before? Well, I'm sure by now everyone, at least all the ICU fellows here. Anyone in the back not know what proning is? So simple approaches is that supine, prone, supine, prone, but now for your entire body. So, really why to be prone? There's a few different reasons why we do it. I'll go into a bit of the history. But really your biggest reason is in patients who are struggling for hypoxia because of ARDS. And that's where primarily the literature comes from. And we'll kind of go over the approach, the evidence, what we've learned in the COVID era, and not just in the COVID era, but things that we start to do more that we actually had evidence for beforehand, and kind of where we're at right now. And then from more of an ICU perspective, what do you guys need to do in managing these patients on the vent when they're proned, or even when they're not on the vent, how you can help your nursing colleagues who've never proned before. So for example, if you guys go to a facility or a community center where you're full of new nurses who have not had any experience proning, what can you guys do to get them on board and successfully lead a proper proning protocol? So I don't think anyone here, at least all the fellows, need a primer on ARDS, but I mean, by now you guys all know what it is. It's been a definition that's been around for since like the 1960s. And a lot of you guys have trained in the COVID era, so you guys are more than familiar on it. But even now, I think my favorite analogy, which I think applies to this lecture of, what ARDS is that it's really just a lung that's in shock, right? We talk about like sepsis, why it's so bad. It's because there's a diffuse inflammatory response. But now imagine that diffuse inflammatory response that's progressive and slowly turning your lungs from this nice pliable balloon, your alveoli, into eventually a fibrotic tissue, or like a rock, right? And that's what's happening with the rest of your body in like an overt SIRS response, but really heightened in your lungs. And so it's a syndrome, right? It's not your final diagnosis, but that syndrome, can cause really pathological damage to tissue. And anyone know what kind of damage it causes to the tissue? Sorry? Yeah, so there's a whole sequela of things that can happen down the line, right? And so there's it's not, I think one thing to keep in mind is that there's many things that are going on that's causing at the end stage a fibrotic tissue. There's like cell growth, there's diffuse alveolar damage, and we'll kind of get into that in a second. But what's important to recognize is that all of that is contributing significantly to inability to oxygenate, right? That there is diffusion impairment, There is increased VQ mismatching. There's a lot of shunt physiology going on. So all that pathophysiology is at play, and that's why you're no longer being able to oxygenate that patient despite high amounts of positive pressure, or even increased FiO2. And so I'm sure everyone's kind of clear on that. And so, there's once again, it's a syndrome. There's many, many different causes of what can cause it. We don't have to go into all of them, but as you guys can see, there's like a long list of what's common is common. Like very commonly we see inflammatory causes, or you can see indirect lung injury, right? So patients that are having a surge response from something else, such as pancreatitis or an infection somewhere else, that now is the body is having an overt inflammatory response and damages the lung, right? We talked about that shock lung analogy, or even like trauma. And then what's less common is less common, which, we don't see here because we don't have much trauma, but like severe trauma, pancreatitis, certain type of drugs, not just a body's reaction to that drug, but being on that drug for a while, such as like an overdose or exposure, like, the classic one is like amiodarone. And then, like patients, like a lot of times, if you go in and you touch the lung, so post-transplant patients, and not just from like lung transplant, but from other transplants as well. And then like, burn patients, you can see it in patients that like have near drowning issues. So these are all a long list of things that can cause it. And so these are the types of patients you're thinking about. And, when we talk about what worked for ARDS and what doesn't, there's, evidence for what, and we'll kind of go into like what actually has a mortality benefit, what doesn't. But in all of these approaches, regardless of the cause, it's important not to forget what the inciting precipitant is, because your first step should be to address that inciting precipitant. And so you kind of talked about this, right? Like, and this is how you this is kind of help understand why certain modalities work and don't, right? So I don't know if you guys have seen this picture, but like it's basically going into how things are working at different stages as ARDS progresses, from a histopathological standpoint. And at the end of the day, like the best way to diagnose ARDS is histopathologically, right? Which you guys have seen how unstable these patients are. There's no way you're getting any type of tissue, right? And so that's why over time you've had these like different definitions, the latest one being Berlin. I don't know if anyone has seen the latest definition that they came out with, like ATS, this whole consensus group tried to come out with a new definition. Well, they're trying to stay, the biggest one that they got rid of, everything is pretty much similar, but the biggest one, and the reason I don't like it, that they got rid of is that they're taking away that criteria where it doesn't, one of the exclusion criteria to say that it's not ARDS is that it's not due to heart failure or pulmonary edema. And in the new ATS guidelines, so like a whole consensus group amongst, a bunch of groups, they took that criteria out. And I don't understand why, because now a lot more people will be managed as ARDS or classified as ARDS when I really don't think they should be. And so, in the first 7 to 10 days, you have your insult, right? And then the first 7 to 10 days, then you start to get diffuse alveolar damage, or DAD. And then that kind of, it's a non-specific reaction to some type of lung injury. You get, and what's happening at like an anatomical level is that you're getting like interstitial edema, inflammation, cell hyperplasia, not just of like your alveolar cells, but other inflammatory cells as well. And then because of the hyperplasia, you get this new hyaline membrane formation. And so when you go and biopsy these tissues, the classic like pathological characterization for this entire syndrome of what's happening is diffuse alveolar damage. Now you start to get that fibroproliferative phase, and you're kind of going from something that's reversible to non-reversible. You get like squamous metaplasia, interstitial inflammation by like myofibroblasts. You get deposition of collagen, and not clear how long this phase lasts, but by now the damage is already being done. But really, for most people, probably 2 or 3 weeks. And then finally, some patients who you've not been able to catch this early enough, where you've not been able to stop the body's response to whatever the insult was, this progressive, irreversible fibrotic stage, where you go from like you completely destroy all normal lung tissue and normal lung architecture, and you become this like fibrotic tissue with like a bunch of cysts. And simple word I like to use is your lungs become rocks. And I think that's something that, at least when I explain that to patients and their families, not to patients, but usually to their families, they finally realize, what, this is like an end stage prognosis. The patient's not a candidate for lung transplant. There's really nothing they can do here. And so you can imagine that with all that, you're going to get really bad hypoxemia, right? For all the reasons that we mentioned. And so you guys know this definition is that 2012 definition, really your timing within 1 week of a known insult. You have to have bilateral opacities that's not explained by effusions, by lung nodules or lung collapse. You want to exclude heart failure or fluid overload. Which is why, once again, I really don't like that new definition or that new suggested proposition that they came out with. I'll send that paper after. And then, refractory hypoxemia, right? And what they obviously said was that you have measured by P/F ratios on at least a positive pressure of 5, which, like a lot of time you'll see on rounds, people will be diagnosing patients with ARDS, but like they're on high flow, right? So you really can't say that the patient has ARDS because you're not seeing that they're requiring that P of 5. And so we talk about management, right? Like there's a lot of different papers out there, a lot of questionable evidence of what has mortality benefit or not, right? And so a quick review of what works and what doesn't work is that, we obviously want to focus and try and specify the underlying cause and treat that. Conservative fluid management, trying to maintain the patient net negative, consideration of early use of steroids. It doesn't apply to everyone because, for example, if they're really dealing with the infection, maybe not. If they're way late in the fibrotic stage, the evidence for steroids suck. It's really catching it on in the beginning to suppress the body's immune response, right? And that's what the goal of steroids is. And then, in terms of obviously, as we resuscitate these patients, making sure they're achieving adequate oxygenation without taking away the respiratory drive. And then you have these patients, which is where things get interesting and where our real clinical expertise comes into place is dealing with these patients with refractory hypoxemia, right? And I'm sure you guys are somewhat familiar with all the literature on this. So some papers, like I actually had this question in here, and then I took it out because I was like, as you read more into it, there's a lot of differing opinions and a lot of differing criticisms of the different literature. But based on this, what do you guys think has been able to show? And I might be incorrect here, and maybe some of the attendings on can specify a more correct answer. But which of these, from number 1 to 6, has been shown to have a 28-day mortality benefit? Yeah, absolutely, 2, right? And there is some evidence that in patients with severe ARDS that potentially ECMO does, right? Um, you know, like when you talk about like alternate modes of ventilation, you don't really see a mortality benefit. And then also when you look at the papers that say these methods that have mortality benefit are successful, you also have to look at like, what's their like 96-day mortality benefit, and then that goes away. But yeah, you're absolutely right. Like prone positioning and potentially ECMO, potentially, because there's a lot of criticisms about that literature as well, have a 28-day mortality benefit. And I can send you guys, I have the papers at the end if you guys want them to see which papers I'm referring to as to say why these two have them. And so, in regards to vent management, obviously a lot of stuff out there. There is good evidence for lung protective ventilation. Actually, really good evidence for lung protective ventilation. And there's different ways to do it because obviously we keep evolving in our approach, but maintaining good, prioritizing tidal volumes so that you can minimize pressures, maintaining a low respiratory rate, allowing for permissive hypercapnia or some level of permissive acidemia. I think people will say 7.25. We definitely stretch 7.2 in order to tolerate minimizing the amount of elevated peak pressures, optimizing for the driving pressures, not having to be over aggressive with the oxygenation, really being aggressive from your guys' ends about just trying to go for 88 to 95. And that'll be important when you guys are actually in that process of proning, and allowing for some permissive hypercapnia, right? So there's different ways to approach it. And these aren't like hard and fast numbers, right? But it's important to remember that I think simple way to think about it is allow for permissive everything, right? It's not going to be your perfect patient. So you're not trying to achieve that normal pH. You're not trying to achieve that perfect O2. You're just trying to get this patient by so that you don't cause more lung damage. And we can keep talking about that, but that's a lecture of its own. So really the fun stuff is prone positioning, right? And so for you guys to think about, and we can actually do a quick poll here. There's many different theories about this out there, and what I'll try and do is I'll try and use actual evidence to try and explain why prone positioning actually works. So Raise your hand if you think it's due to redistribution of blood. Yeah. Yeah, a fluid. A fluid. Yeah. Okay, raise your hand if you think it's because you're getting improved chest wall compliance. Yeah. And raise your hand if you think it's because you're getting increased alveolar inflation. All right, raise your hand if you think it's all three. All right, cool. So this is a very, very nerdy lecture, right? Because we'll try and go through the physiology and try and justify each one. And then it'll kind of help explain why it can even work in patients that are autoproning. Have you guys heard that term before? Yeah, or like self-proning. You're not like having someone else do it for you, you're doing it yourself. And so, like quick little history, prone positioning is not new, right? It's been around. There's evidence for it since around the 1970s. And really, the idea came about to try and improve gas exchange in patients that are having respiratory failure to improve their PF ratios, specifically in patients who are mechanically ventilated and have severe ARDS. And so this paper comes out in 1988 that first describes it. Or sorry, the 1970s was the first paper, and the second one comes out in 1988 again with trying to explore prone positioning and improvement in PF ratios in mechanically ventilated patients. And what they show in this second paper is that there's good evidence of like blood flow and ventilation redistribution. You get improvements in your FRC. You get improvements in hydrostatic areas based on imaging, in like really dependent areas, which are in the back. But then what they realized, what they saw was that when they're actually trying to translate this like physiological benefit that they showed in these papers into actual clinical benefit, they didn't see any. And they did a few randomized controlled trials, but it failed to show any survival benefit. And then obviously it wasn't until also in this paper, this is one of the 1980s. I don't know if you guys know this guy. I hear by the name of Gattagnoni. You guys have probably read some of his papers. He's like this European intensivist, really into physics and physiology. Published a lot of like the good thinking behind what we've done in the last 20 years. But it wasn't until obviously our once again they weren't able to show any benefit in these two in papers that came out afterwards, 2001, 2004, big RCTs trying to show the benefit of proning, no benefit until you get the placebo trial. And this was like the first trial that actually shows that this might be like a widely accepted therapy that can actually reduce mortality in patients with severe ARDS. And so, has anyone here read the paper? Yeah, you guys will all read the abstract and all that. But it's a really well done paper. We'll kind of go into it. And so I think, this will be the one paper we properly review. And the question that they were asking was that, does early application of prone positioning improve survival amongst patients with ARDS? I'm going to try and fly through it because it is a landmark trial. There's a lot of like stuff out there to kind of review it. But I'll kind of go through some of the important stuff. So what they did was it was a multi-center prospective randomized control trial. They did between 2008 and 2011 in 26 ICUs in France and one in Spain. Their criteria were really patients with ARDS as not the Berlin criteria, but the American European Consensus Conference criteria, which is the one before the Berlin criteria. Patients had to be intubated and on the vent for less than 36 hours. And they obviously were using severe ARDS definition as PDF less than 150. For Berlin, what's the severe criteria? Yeah. And then on at least 60% FiO2 and a PEEP of 5. And then, exclusion criteria. So they're excluding patients who are hemodynamically unstable, patients who have elevated intracranial pressures, really facial trauma or severe other trauma. And then if they were pregnant, if they were non-invasive for more than 24 hours, which I'm sure all of you guys are like thinking about back to your COVID days. Very few of our patients were on non-invasive for less than 24 hours. If they had another comorbidity with life expectancy of less than 1 year, and if they had a DVT that was being treated for less than 2 days. When you guys think about the exclusion criteria, what's the first thought that comes to mind? And this goes not just for this paper, but probably for any paper out there, right? Yeah, exactly. A lot of sick people, right? And so, which, you think about trying to publish something that has benefit. I don't think that it's always a bad idea to exclude these sick people. In an ideal scenario, yes, but otherwise it's really hard to show benefit of anything, especially in like the ICU world. And so, what they did was they had about 466 patients who met criteria for severe ARDS. They were randomly assigned to each group. They underwent 16 hours of proning or no proning. And when you look at the characteristics across the two groups, they were pretty much similar, except that the ones in the prone group had a little worse Q-SOFA scores or were on vasopressors or neuromuscular blockade for longer. The left column is supine, the right column is patients that were prone. I don't know if you guys can even see the numbers. But really, I think not that much different. So once again, really good study. And then so, in terms of like the vent protocol, I think that's pretty important. It's not too different from what we're practicing today or what the evidence supports today. All these patients were in volume control modes. They aimed for a tidal volume of 60 Cs per ideal body weight. The FiO2 and PEEP were specifically adjusted to an ARDS-net protocol. I know most of us don't really use the ARDS-net protocol. Most of us, I think, are using driving pressures. Depending on the vent mode we're on, some of us might be using a stress index, but I think most of us are sticking to driving pressures. And then obviously like being very aggressive about making sure they're not over oxygenating. And then so really the results, right? Their primary outcome was a 28-day mortality. And in patients from prone to compared to supine, 16% versus 32.8%, right? So that's pretty good, right? You guys know what a hazard ratio is? So like really it's like what you're saying is like in patients that so a number greater than one is bad, right? That meaning like the ratio of people that got the treatment and died versus those that didn't, greater than one is bad, right? And so ideally you want less than one because that means that under the treatment arm, more benefited. And so it's pretty good, right? 0.39 with an amazing p-value. And then you look at the secondary outcomes, it's like their classic Kaplan-Meier curve. You can see obviously a big benefit. And so even with the 90-day mortality benefit, you still saw it. It didn't disappear like it does in some of the other management interventions that we do for ARDS. Then you looked at the breakdown of specific patient populations. Not as much of a not as beneficial in patients who got a pneumothorax, patients who were on non-invasive. How many were on a non-invasive at 28 days after? Maybe some residual lung injury. You saw that there was obviously much higher in the patients that never got proned. And how many were on non-invasive at 90 days? That's interesting. It's not that high a group anyways, in either cohort. My thinking is that may have some other concomitant lung disease or they've reached that fibrotic stage, and that's why they're still requiring non-invasive for so long afterwards. How many were trach, and obviously not a crazy difference, but obviously there's some benefit there too. Fewer patients were trached at a month and at 3 months if they were under the proning arm. Yeah, and we don't know if that's something else, right? Maybe they had some other causes of lung injury, right? Maybe they were causing like self-induced lung injury beforehand. Maybe it was ventilator-induced lung injury. And so, and it's actually a criticism of this paper is that in patients that were excluded for whatever reason from this trial, we don't know what happened to those patients. The way the authors designed the paper is that they wanted information on patients that ended up being excluded, but they weren't able to get that information from all these different hospitals. And so, you can see that like the rate of successful extubation is significantly higher in the prone group. The duration of mechanical ventilation, length of ICU stays were also lower in the prone group. Incidence of complications didn't differ much, except for cardiac arrest, which was higher in the supine group. I think it was like 16 versus, let me see my notes. There were 16 cardiac arrests in the prone group versus 31 in the supine group. Yeah, it's kind of the stuff we just went over. And so, obviously, like your usual criticisms of a paper, the strength of that obviously was well randomized. It was a multi-center trial. Numbers are important. An overall well-defined study protocol. I think it's well appraised by most of the critical care population. They did do an intentional to treat analysis, which means that they were analyzed in the group that they were specifically treated for. And then, you kind of talked about weaknesses and, there was a little difference between populations. But when you actually looked at the data adjusting for those differences in like QSOFA scores and the use of vasopressors and neuromuscular blockade, you still saw that benefit. I think this is where kind of things come into play is that all these centers were very well trained and had a lot of experience with prone positioning for at least 5 years. And so, when we talk about being a pro at proning, that does definitely play into kind of like a good study. And then once again, we talked about like minimal data on patients that were excluded. So the question is like, when you take a paper like this, obviously the question is, can you apply it to your practice? Can you apply it to your hospital? And I think after the last couple of years, everyone's had a lot more experience. So I think that part is taken out. And then, like this is where like I think my question comes in is that deciding whether, you can go either way and saying whether it's a strength or a weakness, is that when patients were included after patients were included in the prone protocol 12 to 24 hours after they met OS criteria. So this maybe, you can say that it contributes to the selection of patients that may benefit, because you're saying that those are the patients that are going to that more severe ARDS arm, and they're the ones that would benefit from having a significant improvement after prone positioning, such as like transient relief of hypoxemia or prevention of ventilator-induced lung injury. And so people didn't really adapt it after this paper came out. You still didn't see a big adaptation of prone positioning. So come 2017, a consensus group in CHEST decides to publish really pushing for prone positioning. And even then, you're still not seeing much adoption. So like this whole consensus group, similar authors to the one that just came out with the revised ARDS guidelines, really supporting and really pushing for prone positioning as routine management of patients who are in severe ARDS, or sorry, I think they said moderate to severe ARDS, and really, saying that at least 12 hours per day with strong recommendation, and based on the evidence, a high confidence of benefit for it. So, the trial really does that. There was actually another paper that came out, I think, in 2019, very similar to the placebo trial, again, showing I forget what the name was, something that is like very similar to the placebo trial that came out, just not as big numbers. But obviously now you have good evidence that patients with ARDS and severe hypoxemia would benefit from prone positioning when used early and with relatively long sessions. But the question remains, that question that we ask is, why does it work, right? Does it make a difference? I don't know, because we see that it works. Let's just keep doing it. So the first one, right, saying redistribution of blood flow. You're basically saying that you're shifting fluid from, right, you have someone in a dependent lung position, you're lying on your back, and then you have all the blood flow at the bases, and then you flip them over and you're getting a redistribution of blood flow. The idea is that you're going to improve ventilation perfusion mismatching, right? You guys remember the VQ mismatch equation, right? You're technically improving that. So how can we study that? Well, they did studies on this. They did PET scans in a bunch of animals and humans to see whether you actually got blood flow redistribution in the lung. And what you saw was that all the change was transient. You would get on the left, you see a picture of what they were like before they were prone. You did a PET scan, and then you flipped them over for a bit, and then you rescanned them after you flipped them back, and you didn't see that much of a change. And I think this kind of helps explain, maybe it does have a factor here, because a lot of the times you'll see that the benefit is only transient. When you go from supine to prone, you flip them back, you'll have a benefit for a while, and then the benefit goes away. And so when the patients are in the prone position, right, most of your perfusion is happening dorsally, right? And so lung densities may redistribute because you're now being able to better ventilate those areas. But once again, based on this imaging evidence, you only saw a transient. So it could support that this benefit is only transient. Yeah, that kind of makes sense. And so the second one, what about like chest wall compliance? You guys remember the equation for compliance? Change in ventilation over perfusion. So, right, someone with really good compliant lungs, which is like the inverse of elastance, you'll be able to, have a big change in your tidal volume with a minimal change in your pressures, specifically your driving pressures, right? So high delta volume over a low delta change in pressures means you have a compliant lung, right? Um, so what's like a less compliant lung? A normal lung or an RZ fibrotic lung? Which one's less compliant? Yeah, absolutely, right? You're not, for the same amount of volume that you'll try and give, your pressures will increase dramatically, right? And so the idea was that, okay, maybe by flipping someone over, you'll get more chest wall compliance. Well, when you actually look at like anatomy, right? What's in our back of our, in like ventral, dorsal, what's in the back? Your spine, right? And you have ribs, right? And where are the ribs more dense? In the back, right? And you could argue that, okay, maybe you have the heart in the front, right? And maybe that's causing decreased compliance. Maybe the diaphragm's pushing in the front, and that's what's causing decreased compliance. But you know, the dorsal chest wall overall is less compliant than the ventral chest wall, which makes sense because like the spine, motor rib density, which leads to, when you flip them over, an overall net decrease in chest wall compliance when you make them prone, because now you have this whole, and now it's even worse because now you have this area is prevented from expanding, right? Because you're sitting on a bed now, right? So this area can't expand as well. So really, that really can't be the reason. And then finally, but there is the benefit that now your heart is no longer gravitationally pushing down on your left lower lobe. And then finally, the third theory, which is like alveolar inflammation. Anatomically speaking, we talk about like, I think the best way to do it is, right? Have you guys seen this diagram, like the cone in the cylinder diagram? So these are your two lung side. Oh man. Yeah, I just want to show up for everyone online, but that's fine. All right, so like this, like cone in a cylinder diagram. And so this is your lungs, right? This is you lying flat. When you think about overall your lung density, it's much higher posteriorly than it is anteriorly. And so you have all your little alveoli like this. And what you do is when you flip them over, your cone is inverse. And when you talk about like VQ mismatching, right? Where are you going to get more ventilation? Where are you going to get more perfusion? When you're lying like this, you're going to get more ventilation up here, more perfusion up here. When you flip them over, you're going to get more perfusion up here, more ventilation up here, right? And because you're able to ventilate those areas more, you're able to open up these alveoli more. And then these ones will obviously go down, right? You're able to ventilate those areas even lesser. And so it's like the cone in a cylinder analogy. And the idea is that you're trying to better match your lung shape to make it more homogeneous versus less heterogeneous, which is what we're doing when we are supine. So another benefit obviously here is that a little bit of the benefit of the heart, right? Your heart is no longer pushing down in that left lower lobe, which, I think brings up a good question, is that when we talk about like autoproning, I don't know if anyone like tried this out. I know COVID, we had a lot of patients try out. So some of the residents and I would do this. In which side do you think patients would get better oxygenation, the left side or right side? Yeah, right. Kind of makes sense, right? Because you're taking the heart off that lung, that left lower lobe. And the idea is that you keep them in this position for as long as you can, at least in overall recruitment in these dorsal lung regions. And that'll outweigh the amount of de-recruitment that you're getting in the ventral lung regions, leading to an overall increase in lung compliance, not chest wall compliance. And this also explains why we don't typically see an increase in your plateau pressures in the long run. You'll see it transiently, which I'll get to. And then another reason is also because of these like overall long term, you're not getting worsening plateau pressures. It's why, like it also helps prevent ventilator induced lung injury. And I think that's why we saw that benefit. Because you're overall redistributing like, the strain on the lungs and the overall stress in the lungs. So I think overall you are getting better blood supply, better VQ mismatching, but really the key here, I think, is alveolar inflation. And there's actually a paper that went and looked at all this and like dog models. Um, and so, obviously, like some things that we learned in COVID, before and after COVID, is that, you saw that, okay, like I think this was 2015. You can see patients that this is before COVID. In patients that are developing ARDS or even just hypoxemia, they would push these patients to autoprone. It was like a great paper, but I think this was the first paper I could find that really showed it. They looked at non-intubated patients. It was like a retrospective case series in patients who had hypoxemic respiratory failure. They proned them and they saw benefit. I think most of these patients were sick because of pneumonia. Um, and they would perform, I think, overall on average proning 43 times. Sorry, overall, all of them, so about twice per patient. And in these patients, like oxygen was being provided with like a face mask or BiPAP. They didn't really have non-invasive, I mean, high flow. They did like anywhere from 3 to 8 hours, which I'm sure you guys have all had experience telling your patients to do that. And in what they realized was in this paper, what they showed in this retrospective series is that these patients were maintained on the same amount of respiratory support through that entire proning period. But the benefit was only transient. Meaning at the moment you flipped them back, you didn't get that persistent benefit and their O2 requirements would increase. Oh, wow. This is what I was showing about like the little cone model. So you can see how like it becomes more like this area suffers, right? You're getting less compliant, but overall you're getting more compliant. And recruiting all that alveoli in the back, right, which is much more dense in that bottom part of the triangle. Um, yeah. System standing up. Like that. Yep. PowerPoint. I'm using PowerPoint from 2012. Well, you get the latest version through work for free. Yeah, all of us do. We all get Office 365 for free. No, through Inspiro. Wait, all of you guys do. If you just download Office 365 and then enter your username and password, you guys get the latest version of PowerPoint. Yeah. We also get access to Copilot, which gives you AI on all Office apps. Yeah. Yeah. On all our Office apps. It only takes about an hour to create these presentations now. Yeah. All right. Anyways, I know you guys want breaks. All right. All right. So basically, you see this benefit, right? So you've seen that all that benefit is only transient. The moment you flip them back, their oxygen requirements go back to having increased amounts. And so they took this and like obviously like a lot of data out in China. You saw that this was like the first article I could find that showed evidence of autoproning in awake COVID patients. And they did, obviously so many people around the world deployed this as a strategy to try and prevent intubation. They had patients on high flow, on BiPAP, and obviously everyone is being thrown the kitchen sink here, so we don't know whether the benefit here was due to proning or due to something else. But in the many things that were being thrown at them, this was obviously something that was being thrown very aggressively. Um, uh, had a friend that was part of this paper. This was out in the Lincoln ED out in New York. They had patients on nasal cannula on non-rebreathers. They didn't have any high flow, so they excluded patients from that paper. And they saw that patients initially were less than 84% achieved saturations on 94 from 84 to 94 on average, just by proning patients in the ER. Once again, not like a crazy amount of patients. I think how many? 50 patients. And of those, 18 still did end up being intubated anywhere from like the first day to like the next 3 days. They would do it in the ER anywhere from like 30 minutes to 2 hours. And they would keep flipping up. So what they do is like left lateral decubitus, completely upside down, then right. So then sit back up for a bit, then left, right. And they just keep doing that in the ER. Very, very aggressive. And you can imagine, like, I think the cool part about that is that it's a very resource limited area. and they were able to implement that. Um, so yeah, blah blah blah. More papers kind of showing that benefit. Um, why did I include this one? This one was a patient. I think it was a case report here. Really bad COVID pneumonia. They were on high flow and nasal cannula. Oh yeah, this one was being only on high flow. And then they self-prone for 16 to 18 hours a day, including 8 to 10 hours at night. Um, and every time they would measure their oxygenation on a graph and they would record their PDFs and they would see the improvement in PDFs while he was prone. And they would flip them back. I think it was a little unfair to try and keep, kind of torturing this guy with ABGs for a study. But you can obviously see. But the cool part is that he would like eat, communicate with his family, participate in PT. They didn't prone for a while because he had kept having nosebleeds. And then yeah, once again, what you're seeing in patients that were intubated is that the benefit is completely transient. I think this was a study out in Boston. They would have PDF ratios improvement from like median of 150 to 230. You wouldn't get a significant increase in compliances. These are patients that are on the vent. But then what problem is like what was cool about this paper was that then you actually saw the benefit that the PDF would somewhat remain increased even after supinating them. And the compliance would kind of remain elevated too. It didn't go back down to where it was before. Um, so obviously benefit, benefit, benefit. Um, the cool part about autoproning is that like, having patients that, and I think maybe it's been forgotten thing, like you'll see patients that are old are getting, like you get a consult for patients that potentially need to be intubated. They maybe are wavering on the idea of not being intubated. So you're trying to buy them time to help make that decision. One thing that you can still offer, if the primary team doesn't remember, you guys can remember, is to suggest proning, in addition to all the other stuff like diuresis, because it's cheap. It doesn't take a lot of manpower, especially with auto proning. The nurses here are overall very comfortable with it. It's very easy to teach a nurse what you're asking of them. Um, what I like to do is like I like to record the time and have the nurse record the time so they can keep track of how aggressive are they actually doing it. And other cool is that you don't have to do all the other bad stuff that we do, right? Like paralyzing patients that we do in patients on the vent. Um, Very tough ask to do in a big chunk of our patient population, which is our obese patients. Even the ones that are intubated, I think overall, I would say our group here as a whole, especially a lot of credit to our nurses and attendings. Even with obese patients, we'll still do it. And because we have methods to do it. Have you guys ever seen the NAGEM video on how to prone? The NAGEM video, like on the actual paper. The paper actually published a video, the authors, on how to prone. And I looked at that video and we do it completely differently. They don't put pillows on top of the patient. In the second, like we put 3 blankets to make that little burrito. So what we'll do is like have you guys, yeah, so what we do here is like so we lie the patient, well, I'll go into it, but we lie the patient flat. We put a sheet underneath first, and then we'll put a sheet over. Then we'll put a bunch of pillows, and then we'll put another sheet over. And then from both sides, then you make a little burrito. You'll roll one side up, the other side down. So you have 3 sheets, and then you move them to one side, usually to where the ventilator is, then flip them, and then flip them over, and then they just fall onto the pillows, which is perfect. So you get a lot of like, you don't get a lot of like tissue injuries and things like that. And with that burrito method, still not easy, but a lot more successful at proning obese patients. And then I remember seeing a picture of this on Twitter. They use like these pregnancy beds for obese patients. So it has like a big hole right here for like their, I forget what the right word is, like their penis, like protuberant abdomen. Um, and you can actually do the same thing with the pillows, right? You just put pillows everywhere else and don't put a pillow here. And it would allow you to really prone these obese patients, still getting that benefit of that overall alveolar inflation. Um, the way I like to like the question is like how would you guys describe it to families when you're trying to tell them to be very aggressive about this? Yeah, or like why it's working. I think when they understand the benefit, like you'll tell, I don't know how what your guys' experience is, but we'll tell families to do this or we'll tell patients to do it. And they're like, yeah, I'll do it. And you walk back in every time and they're like lying on their back, right? And so one way that I found that somewhat works is explaining to them why it works. And I'll like draw it out on the whiteboard. And what I'll tell them is like, you're squishing your lungs are like a bunch of balloons. And I used to like walk around with balloons. I know an attending did it, and I saw an attending do it. I was like, I have to do this. So he would put like a book on the balloon, like a thin book, and then he would try and blow up the balloon, and he'd work really hard to blow it up. And then he would flip them over and put the book underneath, and then try and blow it up, and he'd see how much quicker the balloon would inflate. And he's like, "This balloon is your lungs. Imagine 1,000 of these that you're no longer being able to inflate, but now you flip over and have this BiPAP on, and do it for hours and hours and hours, all this lung tissue will start to inflate. All your balloons will start to inflate." Sorry? Same thing. Swimming. You put them in a swimming mode. So like you have one hand up, one hand down, and then you keep one on the side and then have the BiPAP mask on. Some paper book, I don't know. Yeah. Whatever I had my wife at the time. Or my like gigantic heavy phone. Yeah. Um, so I think when it comes to more like the expert level of proning, things that you'll see is so, I think Chest had this pretty cool guidelines of like what things you should keep in mind as you're doing it. And I think checklists are always important. And I think that whenever you guys prone, especially if you don't have much experience, should always print out a checklist and really not be involved in the process. Like get as many hands as you need to so that you can focus on leading the entire team. Key things to do is obviously disconnect everything. And I really want to optimize them. Like wait till everything else is ready and then disconnect, right? Like disconnect the A line, disconnect them from the vent, have the respiratory therapist bagging, clamp up all the tubes of the central line. I think what helps in this case is like having the end tidal CO2 on, obviously like things that you might forget that I know most of us will forget, like temperature probes and things like that. And then as soon as you flip them, make sure to reattach all of it. And the first thing that I go for is putting them back on the monitor. I don't want to leave that area until I see where they are, if they're stable on the monitor again, and especially their pulse ox. Bedding wise, obviously making sure that you have enough bed sheets ready. Tips are like when you are going to schedule a prone, like at 1:30, let the nurses know like at 1 o'clock to start getting all the sheets ready. And even like letting the nurse know beforehand, come by at 1 o'clock and say, hey, can we start getting all the pillows and sheets now? Because then everyone will arrive at 1:30 and then you'll still be trying to find some pillows. And then after you flip, making sure that because there's a bunch of stuff there, all this ancillary stuff, clearing out the sheets, right? Making sure you get rid of all that. You yourself check all the lines, make sure everything is still good, making sure that A line is still in place, secure. Like all your catheters look good. And then, one another thing is like your Ds for dependent regions. Like you guys have seen like all those like stuff that we put on these patients to prevent tissue injuries. Have to be very, very aggressive about that. Have you guys ever seen all these like ulcers and bad tissue injuries? Like the biggest one that I can't get over is the face. No matter how well you protect that area, it's very hard to protect that area from soft tissue injuries. And obviously we have these like super nice mats and everything, but even then, like some area of the face still has to be on something, right? And the idea is to keep moving all that stuff around. But when you have like, like very strained nurses, like because of like the number of patients or number of sick patients, I mean, these infections get bad, right? Like you literally see, for lack of a better word, like pus coming out of their face, right? And all the tissue just becomes very necrotic. And so obviously being very aggressive about that. And making sure like, what I like to is like mark where the ET2 was. I'll let the respiratory therapist know what I'm trying to do. I'll mark it, and then I'll make sure that it's still in the same position when we flip them back. With catheters, like the patient can have a central line. My opinion is put a central line beforehand, because you never know when you require it, and it's a lot harder to do it when the patient is prone. I've done it once because we really didn't feel comfortable flipping the patient back because there's just such a big benefit. And my recommendation would be to never do it again. I know other fellows have done it too, and all the recommendations is to not try and put a central line in prone. We've done it, but actually, yeah, you can turn to the side and you can do it. Yeah. Level goes the other way. And then obviously like Foley, take the Foley off the bed because it's hanging off the side of the bed. Can you imagine what happens if you don't do that? And then I think one of the area that people commonly, at least what I saw in the beginning, was when we were ignoring the pressure injuries, were like the general area. A lot of bad pressure injuries there, and then we started to be a lot more aggressive about it. I think we started using the face masks that we used in the general area, and that helped prevent pressure injuries. What do you expect to see to happen when the patient's on the vent as you flip them over? As you go from supine to prone? So like, what do you think will happen to your peak pressures? Well, yeah. What do you think that is? Because you're pressing the chest wall. Yeah, you haven't recruited your alveoli yet, right? We talked about the chest wall being the dorsal area being less compliant than the area, and so now you're dealing with all that. And you'll also get so that'll when you talk about like compliance, technically, then you should see an increase in your peak pressures and your plateau pressures, but you also see an increased gradient. So why do you think that is? Meaning that you're getting even worsening airway resistance. Depending on the cause of your RDS, for example, like infectious causes, you'll mobilize a lot more secretions. So proning actually helps you get rid of a lot of secretions, and you'll start to realize that you're getting a lot more stuff out of your ET tube when you suction. And so if the patient's stable, I'll just start suctioning right there. Now, if you see these increase in pressures, you'll also see potentially, and this is important not to freak out about this, is a decrease in your O2 sats. And you don't panic, you just let it be. It'll take a while for them to recruit. And then in time, you'll start to see that decrease in your peak and plateau pressures. So it really just requires a lot of patience. When you looked at that paper where they were trending ABGs, it took a while. You don't have to trend the ABGs. You can also do it to like PaO2s. And I think it's important to realize that some patients will fail proning, right? Maybe they've progressed on the sequela of that algorithm that we saw, that picture that we saw of how the lung tissue gets damaged. Maybe they've progressed in that area. And some areas are worse than the other areas. And maybe the dorsal areas are worse than their ventral areas. And that area may no longer be able to benefit. And now you're getting rid of the only good lung tissue that's left. And so these patients can fail proning. Yeah. Pro for proning. Proning like pro. Questions? I think someone like sent me a commercial of that when I was like trying to explain that to my family, and they showed like, oh yeah, you guys have these like fancy beds for like prone patients. Like, no, we just have like a bunch of nurses that get very, very tired, and a lot of residents that get very, very tired. Yeah, 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 yeah. All right, cool. You guys want to take a 7-minute break? Yeah, it's 2:53. Your peak. Yeah, so that's a good question, right? Like, we can quickly talk about it here, but like, how do you optimize your PEEP? And so there's different ways to do it.
There's a table, but that can be a little aggressive, and I think the whole.
The table is not a bad thing. There's good evidence behind the table, right? But we have more tools in our belt, especially with all these fancy vents. So if you're doing ventilation on a fixed curve like this, like what we do now is like delayed innovation curve where it goes like this, right? But if you're doing this method, you can actually look at your ventilation and perfusion, and you can actually see a curve like this. And that's, you can measure a stress index like this, which is this ratio to this ratio. This one is 1, right?
Wait, Q being,
Perfusion.
yeah, okay, so the BQ to Q index, okay.
Oh, sorry, pressures.
Yeah, that's what I thought. It was like pressure, so.
Yeah. This is your driving pressure. So you can actually measure this. And so this is great. This means that what's happening in your alveoli is that it's like this. Ideally inflated. When your stress index is high like this, right? Your alveoli are collapsed. When your curve looks like this, your alveoli looks like this. Just overinflated. So when it looks like this, less than 1, overinflated, greater than 1, inadequately inflated, 1 is where you want to be. So you keep adjusting your peak, go up or plus or minus 2, and then see that. But keep in mind, this is on a fixed volume curve, not a delayed expiration curve.
Which is what I use.
So for this, what we is driving pressures. Your driving pressure is like your,
Between the flats and the.
yeah, and get your lowest driving pressure, adjust it, do 5 or 6 breaths. Some people say it doesn't work. It takes much longer. It's like,
That's a couple minutes.
yeah, exactly. You lay in the stand with the patient, come back in a bit, see your driving pressures are.
Gotcha.
And then keep seeing like at what peak you get to that. So I'll start off say like a 10 or 8, whatever I'm at. I'll decrease it, see if it gets better, and then I'll increase it. And then if I start to see that I think it gets better, I'll go even higher. I'll try and lose that benefit. And I'll try and get the lowest number and always want it ideally less than 15 or 14.
Okay.
Yeah.
Very cool.
Have you ever,
Oh, sorry.
have you had any of these patients killed?
Oh, hell yeah. So I always have the monitor outside the room. And that's why like my first thing is always, sorry. Yeah. Which is why I always wait to the last second to take the leads off the monitor. And then it's the first thing that we always put back on. Yeah. And then, huh? Yeah. You gotta have a lot of money for that. Ouch. Yeah.